What is the most specific marker of papillary thyroid carcinoma? BRAF V600E point mutations are found in up to 70% of papillary carcinomas but rarely in other cancers and serve as a specific diagnostic marker to distinguish papillary cancer from benign nodules. What thyroid abnormality is seen in Pendred syndrome? Pendred syndrome causes a partial defect in thyroid iodide organification due to impaired iodide transport into follicles. This leads to the thyroid defect known as a positive perchlorate discharge test. How does excess iodine consumption impact thyroid function? Excess dietary iodine can inhibit thyroid hormone synthesis and release, referred to as the Wolff-Chaikoff effect, causing hypothyroidism. This effect is transient in normal individuals as the thyroid escapes from Wolff-Chaikoff. What finding on thyroid exam suggests anaplastic thyroid cancer? Hard, fixed, irregular thyroid enlargement rapidly emerging in the setting of dysphagia, dyspnea, hoarseness suggests anaplastic thyroid cancer which typically presents with aggressive local invasion. What antibodies are present in Hashimoto's thyroiditis? Hashimoto's thyroiditis involves autoantibodies directed against thyroid peroxidase TPO and thyroglobulin proteins within the thyroid follicles. Measuring TPO antibody titers assists diagnosis. What thyroid disorder involves a painful tender thyroid gland and elevated inflammatory markers? Subacute granulomatous thyroiditis causes fever, anterior neck pain, and tender thyroid enlargement along with elevated ESR and CRP reflecting inflammation.
How does the presence of Hashimoto's thyroiditis impact surgical approach for a thyroid nodule? Coexisting Hashimoto's reduces malignancy risk. More conservative resection may be opted for indeterminate nodules with high titers to avoid risks of total thyroidectomy. What are the ATA guidelines for timing of calcium monitoring after total thyroidectomy? ATA recommends calcium screening within 6 hours of surgery, then again at 24 hours post-op. Extended monitoring is appropriate before hospital discharge. How does retrosternal goiter impact the surgical approach? Median sternotomy or lateral thoracotomy may be required for resection instead of the standard cervical approach for very large retrosternal goiters.
What is the thyroid gland? The thyroid gland is an endocrine gland located in the neck that produces thyroid hormones T3 and T4, which help regulate metabolism. What hormones does the thyroid gland secrete? The thyroid gland secretes thyroid hormones triiodothyronine T3 and thyroxine T4. What cells produce thyroid hormones? Follicular cells of the thyroid gland produce thyroid hormones T3 and T4. What is the role of TSH in thyroid function? Thyroid-stimulating hormone TSH is released by the pituitary gland and stimulates the thyroid gland to produce and release T3 and T4 hormones. How does the hypothalamic pituitary thyroid axis regulate thyroid hormone levels? The hypothalamus releases thyrotropin-releasing hormone TRH, which stimulates the pituitary gland to secrete TSH. TSH then stimulates the thyroid gland to produce T3 and T4. The levels of circulating T3 and T4 then provide negative feedback to the hypothalamus and pituitary to decrease TRH and TSH production. What stimulates the release of thyroid hormones? Thyroid-stimulating hormone TSH released by the anterior pituitary gland stimulates the release of thyroid hormones T3 and T4. What is the role of thyroid hormones in the body? Thyroid hormones help regulate metabolic rate, protein synthesis, growth and development, and help maintain body temperature, heart rate, and central nervous system function. Which thyroid hormone is more biologically active? Triiodothyronine T3 is more biologically active than thyroxine T4. What are the steps involved in thyroid hormone synthesis? Iodide trapping, iodination of tyrosine residues on thyroglobulin, coupling of iodotyrosenes to form T3 and T4 within the thyroid follicles, endocytosis of colloid, proteolysis of thyroglobulin to release T3 and T4. What causes congenital hypothyroidism? Congenital hypothyroidism can be caused by thyroid dysgenesis, defects in thyroid hormone biosynthesis such as iodine transport defects, maternal antithyroid drugs, defects in TSH or TRH receptor function, and defects in conversion of T4 to T3. What are the clinical features of cretinism? The clinical features of cretinism untreated congenital hypothyroidism include short stature, mental retardation, skeletal abnormalities, myxedema, large fontanelles, macroglossia, dry skin, hoarse cry, constipation.
What causes myxedema coma? Myxedema coma is caused by long-standing, undiagnosed hypothyroidism leading to severe deficiency of thyroid hormones. It can be precipitated by infection, trauma, medications, or other metabolic stresses. How is myxedema coma treated? Myxedema coma is a medical emergency requiring hospitalization. Treatment involves IV levothyroxine, steroids, respiratory support, fluid management, and treatment of any precipitating factors. Rewarming must be done slowly. What are the causes of hypothyroidism? Causes include Hashimoto's thyroiditis, thyroid surgery, radioactive iodine ablation, external beam radiation, medications lithium, amiodarone, pituitary disorders, and congenital hypothyroidism. What are the signs and symptoms of hypothyroidism? Symptoms include fatigue, cold intolerance, weight gain, hair loss, muscle weakness, joint pain, constipation, dry skin, depression, and slowing of mental processes. Signs include delayed reflexes, hypoventilation, bradycardia, and periorbital puffiness. How is hypothyroidism diagnosed? Diagnosis is made by blood tests showing high TSH and low free T4 levels. Anti-thyroid peroxidase antibodies can help diagnose Hashimoto's thyroiditis. How is hypothyroidism treated? Levothyroxine is the treatment of choice and is very effective at reversing symptoms and normalizing lab values. The dose is titrated based on TSH levels. What causes thyrotoxicosis? Common causes are Graves' disease, toxic multinodular goiter, toxic adenoma, thyroiditis, overmedication with thyroid hormone, pituitary adenoma, struma ovary, and metastatic thyroid cancer. What are the signs and symptoms of thyrotoxicosis? Symptoms include weight loss, heat intolerance, fatigue, anxiety, palpitations, and diarrhea. Signs include sinus tachycardia, widened pulse pressure, tremor, hyperreflexia, and thyroid bruit. How do antithyroid drugs like methimazole and propylthiouracil work? These drugs inhibit thyroid peroxidase, an enzyme required for thyroid hormone production, thereby reducing synthesis of T3 and T4. How is Graves' disease differentiated from silent or apathetic thyroiditis? Graves has autoantibodies TSI and TPO present while silent thyroiditis does not. Graves causes diffuse symmetric thyroid enlargement while thyroiditis causes asymmetric enlargement. Thyroiditis causes pain with swallowing or lying down. How is thyroid storm precipitated and managed? Thyroid storm can be precipitated by infection, trauma, surgery, or abrupt withdrawal of antithyroid meds. It is a medical emergency managed with beta blockers, antithyroid drugs, glucocorticoids, PTU, cooling blankets, and supportive critical care. What are the indications for radioactive iodine therapy versus thyroidectomy? Radioiodine is generally first line for Graves' disease and solitary toxic nodules if there are no contraindications. Thyroidectomy may be considered for large goiters, cold nodules, hyperparathyroidism, or where radioiodine is contraindicated. What are the parathyroid glands? The parathyroid glands are 4 small glands located on the posterior surface of the thyroid gland that produce parathyroid hormone PTH, which regulates calcium levels in the blood. How does parathyroid hormone regulate calcium levels? PTH increases blood calcium levels by promoting osteoclast activity to release calcium from bone, increasing GI absorption of calcium, and increasing reabsorption of calcium in the kidney tubules. What causes hyperparathyroidism? Most cases are caused by a parathyroid adenoma. 80% other causes include parathyroid gland hyperplasia secondary to renal failure, multiple endocrine neoplasia Men's syndromes, and parathyroid carcinoma. How does hyperparathyroidism present clinically? Hyperparathyroidism can cause hypercalcemia, kidney stones, abdominal pain, nausea or vomiting, increased urination, bone pain, and psychiatric disturbances. Many cases are asymptomatic. How is primary hyperparathyroidism treated? Definitive treatment is surgical removal of the abnormal parathyroid gland. Cinacalcet can help reduce calcium levels along with IV fluids, loop diuretics, and bisphosphonates acutely. What is the cause of secondary hyperparathyroidism? Secondary hyperparathyroidism occurs in response to hypocalcemia, most commonly due to chronic kidney disease reducing conversion of vitamin D to its active form. What thyroid malignancies are most common? Papillary thyroid carcinoma is the most common thyroid cancer, making up 80% of cases. Follicular carcinoma makes up 10%, with medullary and anaplastic carcinomas being less common.
How does a thyroid nodule present? Thyroid nodules typically present as an asymptomatic neck mass. Large nodules can cause dysphagia, dyspnea, or hoarseness. They may be hyperfunctioning or cold on radioiodine scanning. How is thyroid cancer staged? The TNM system is used. T1 T4 classifies size and extent of tumor. N1 indicates lymph node spread. M1 is distant metastasis. Higher stages indicate more advanced disease. What is the first-line treatment for differentiated papillary or follicular thyroid cancer? Most cases are treated with total thyroidectomy followed by radioactive iodine ablation of any remaining thyroid tissue. Thyroid hormone suppression therapy follows. How effective is RI for treating thyroid cancer? RI ablation following total thyroidectomy successfully treats about 90% of differentiated thyroid cancers, with recurrence rates less than 10–15%. When is external beam radiation used for thyroid cancer? External radiation may be used for anaplastic thyroid cancers or locally advanced papillary or follicular cancers not amenable to full surgical resection. It helps improve local control. What types of thyroid cancer have the worst prognosis? Anaplastic and medullary thyroid carcinomas have the worst prognoses. 10-year survival is 10-20% for anaplastic and 40% for medullary cancer. Well-differentiated papillary or follicular cancers limited to the thyroid have excellent prognosis. What genetic syndrome causes medullary thyroid carcinoma? Medullary thyroid carcinoma is commonly associated with multiple endocrine neoplasia men type 2. The RET proto-oncogene causes uncontrolled growth of C cells leading to medullary carcinoma. How is medullary thyroid cancer treated? Total thyroidectomy with central lymph node dissection is the mainstay of treatment. External beam radiation, chemotherapy, or tyrosine kinase inhibitors may be used in advanced cases. Calcitonin levels are used to monitor for recurrence. What is Van Wyck-Grumbach syndrome? Van Wyck-Grumbach syndrome consists of juvenile hypothyroidism, delayed puberty, and prolonged menstrual bleeding in girls due to an autoimmune atrophic thyroiditis. Treatment is thyroid hormone replacement. What thyroid disorder involves episodic painless thyroid enlargement? Subacute granulomatous thyroiditis, also known as de Quervain thyroiditis, causes painless thyroid enlargement along with fever, fatigue, and thyrotoxicosis. NSAIDs and steroids help treat the inflammatory symptoms. What autoantibodies are characteristic of Hashimoto's thyroiditis? Hashimoto's thyroiditis involves autoantibodies against thyroid peroxidase TPO and thyroglobulin proteins in the thyroid. Elevated TPO antibody titer is diagnostic. How does amiodarone affect the thyroid? Amiodarone can cause iodine-induced hyperthyroidism or hypothyroidism by inhibiting T4 to T3 conversion and altering thyroid hormone synthesis and release. Thyroid function should be monitored when taking amiodarone.
What thyroid disorder involves thyroid follicles with scalloped borders? The scalloped or irregular follicles are characteristic of Hashimoto's thyroiditis and develop due to chronic inflammation and scarring of the thyroid tissue. What is the thyroid disorder renal thyroiditis? Renal thyroiditis is a very rare chronic fibrosing disorder characterized by a densely fibrotic, rock-hard goiter that can extend beyond the thyroid capsule to invade surrounding tissues of the neck. What congenital syndrome involves thyroid dysgenesis along with choanal atresia? The Charge syndrome involves coloboma, heart defects, atresia of the choana, retardation of growth or development, genital abnormalities, and ear abnormalities. Many cases involve thyroid dysgenesis. What is the McCracken spoon? A McCracken spoon is a concave deformity or scooped-out appearance of the nails seen in long-standing overt hypothyroidism due to accumulation of mucin in the nail bed.
What genetic mutation causes familial medullary thyroid cancer? An activating mutation in the RET proto-oncogene leads to uncontrolled growth of parafollicular C cells and familial medullary thyroid carcinoma, seen in men too. What is the Wickham survey? The Wickham survey was a 20-year epidemiological study of thyroid disorders in the UK that provided key data on prevalence, incidence, and risk factors for hypothyroidism and autoimmune thyroid disease. What US features are suspicious in a thyroid nodule? Suspicious ultrasound features include microcalcifications, hypoechogenicity, increased nodular vascularity, irregular margins, and a tall rather than wide shape. Benign nodules are often hyperechoic. What does thyroid peroxidase do? Thyroid peroxidase TPO is an enzyme expressed on the apical surface of thyroid follicular cells that catalyzes reactions important for thyroid hormone synthesis including iodide oxidation and iodination of tyrosines on thyroglobulin. What causes thyrotropinoma? Thyrotropinoma is a pituitary adenoma that autonomously secretes TSH. This leads to hyperthyroidism due to overstimulation of the thyroid. Treatment is transsphenoidal surgery with possible radiation therapy. How does lithium cause hypothyroidism? Lithium inhibits thyroid hormone release leading to hypothyroidism. It also impacts thyroid autoimmunity and impairs thyroid hormone synthesis by interfering with iodine uptake. What mutation causes resistance to thyroid hormone? Resistance to thyroid hormone is caused by mutations in the THRB gene encoding the thyroid hormone receptor beta. This leads to variable tissue hyporesponsiveness to thyroid hormones T3 and T4. When does postpartum thyroiditis occur and how does it present? Postpartum thyroiditis occurs within the first year after delivery, causing painless thyroiditis, hypothyroidism, and possible subsequent hyperthyroidism. Anti-TPO antibody positivity predicts increased risk. How does amiodarone induce hypothyroidism? Amiodarone contains a large amount of iodine that inhibits thyroid hormone synthesis and release. It also damages thyroid cells directly causing destructive thyroiditis in some patients leading to transient hyperthyroidism then hypothyroidism.
What thyroid antibody levels are evaluated in Hashimoto's thyroiditis? Hashimoto's thyroiditis involves elevated levels of antibodies against thyroid peroxidase TPO and thyroglobulin proteins. Measuring TPO antibody titers assists diagnosis. What causes congenital hypothyroidism? Congenital hypothyroidism can be caused by thyroid dysgenesis, deshormonogenesis including defects in iodine transport or thyroid hormone synthesis enzymes, hypothalamic or pituitary hormone deficiencies, or exposure to maternal antithyroid drugs. What thyroid disorder involves episodic unilateral thyroid enlargement and inflammation? Subacute granulomatous thyroiditis. De Quervain's thyroiditis involves episodic painful inflammation and enlargement of one thyroid lobe, often preceded by viral illness. It generally resolves spontaneously over weeks to months. What is the thyroid therapy guidelines? The thyroid therapy guidelines published in 2012 outline an algorithmic approach to thyroid dysfunction diagnosis and treatment, including reference ranges for TSH, indications for combination T4 or T3 therapy, and optimal thyroid hormone targets. What thyroid antibody levels are evaluated in Graves' disease? Graves' disease involves autoantibodies that stimulate the TSH receptor TSI, as well as antibodies against thyroid peroxidase TPO-ABS and thyroglobulin TG-ABS. How does pregnancy impact thyroid physiology? Increased estrogen causes a 50% increase in thyroxine-binding globulin, which increases total T3 and T4, but free levels are unchanged. The thyroid gland enlarges 10% in iodine-sufficient areas. HCG can stimulate the TSH receptor, causing gestational hyperthyroidism. What is the cause of tertiary hypothyroidism? Tertiary hypothyroidism is caused by lack of TRH production or secretion from the hypothalamus, leading to impaired TSH production and subsequent thyroid hormone deficiency. How does thyroid hormone impact bone metabolism? Thyroid hormone increases osteoblast and osteoclast activity, leading to increased bone turnover and resorption. Hyperthyroidism causes increased risk of osteoporosis, while hypothyroidism slows bone turnover. What thyroid disorder can present with painless thyroid enlargement, weight loss, anxiety, and bulging eyes? Graves' disease is characterized by hyperthyroidism along with diffuse symmetrical thyroid enlargement, ophthalmopathy, and pretibial myxedema in some patients. What causes toxic multinodular goiter? Toxic multinodular goiter occurs when one or more autonomously hyperfunctioning thyroid nodules within a goiter lead to hyperthyroidism in the context of overall reduced TSH stimulation and thyroid atrophy. How is thyroid storm treated? Thyroid storm is a medical emergency requiring aggressive treatment with beta blockers like propranolol, antithyroid medications, iodine solutions to inhibit thyroid hormone release, corticosteroids, cooling blankets, and supportive critical care. What is the most common cause of hypothyroidism in developed countries? Hashimoto's thyroiditis is the most common cause of hypothyroidism in iodine-sufficient developed countries, caused by autoimmune destruction of the thyroid gland. What genetic disorder causes metabolic defects in thyroid hormone synthesis? Pendred syndrome is caused by mutations in the pendrin SLC26A4 gene, leading to impaired iodide transport into thyroid follicles and congenital hypothyroidism along with hearing loss. What is the treatment for anaplastic thyroid cancer? Anaplastic thyroid cancer has a very poor prognosis. Multimodality treatment with surgery, chemotherapy, and radiation is often given, but median survival is less than 1 year after diagnosis. What thyroid abnormality is associated with Down syndrome? Up to 50% of patients with Down syndrome have subclinical primary hypothyroidism caused by thyroid dysgenesis and autoimmunity. Annual thyroid function screening is recommended. What is the most appropriate next step when a thyroid nodule biopsy is non-diagnostic? Repeat fine needle aspiration should be performed for initially non-diagnostic cytology. If repeat FNA is non-diagnostic, molecular testing or diagnostic thyroid lobectomy are options. What is the Damile relationship and what thyroid disease does it describe? The Damile relationship describes the association between amenorrhea, myxedema, lymphocytic leukemia, and eosinophilia in patients with Hashimoto's thyroiditis. How does subacute granulomatous thyroiditis typically present? Subacute granulomatous thyroiditis usually presents with painful subacute thyroiditis, transient thyrotoxicosis, and a triphasic clinical course progressing to euthyroidism or hypothyroidism before recovering thyroid function. What antibody is used to monitor for recurrent medullary thyroid cancer? Serum calcitonin levels are monitored in patients with medullary thyroid cancer history to screen for recurrence, as calcitonin is secreted by the C cells that become malignant in MTC. What thyroid disorder involves episodic unilateral painful thyroiditis? Subacute granulomatous thyroiditis. De Quervain's involves episodic painful inflammation of one thyroid lobe, often preceded by viral illness. It generally resolves spontaneously over weeks to months. Which thyroid cancers demonstrate soap bubble nuclei histologically? Papillary thyroid carcinoma is characterized by ground glass overlapping nuclei resembling soap bubbles on histology along with nuclear grooves and intranuclear pseudoinclusions. What causes thyroid dehormonogenesis? Defects in key enzymes required for thyroid hormone synthesis like thyroperoxidase, dual oxidase 2, pendrin, thyroglobulin, and dehalogenases can all cause dehormonogenesis. Most cases are inherited autosomal recessive traits. Why is TRH stimulation testing useful in evaluating hypothalamic or pituitary disorders? After IV TRH administration, an absent TSH response indicates hypothalamic dysfunction while a delayed blunted response indicates pituitary pathology. A normal response rules these out. What is Sheehan syndrome? Sheehan syndrome is postpartum hypopituitarism caused by ischemic pituitary necrosis due to severe intrapartum or postpartum hemorrhage. Central hypothyroidism results from loss of thyrotropes.
What is the most specific marker of papillary thyroid carcinoma? BRAF V600E point mutations are found in up to 70% of papillary carcinomas but rarely in other cancers and serve as a specific diagnostic marker to distinguish papillary cancer from benign nodules. What thyroid abnormality is seen in Pendred syndrome? Pendred syndrome causes a partial defect in thyroid iodide organification due to impaired iodide transport into follicles. This leads to the thyroid defect known as a positive perchlorate discharge test. How does excess iodine consumption impact thyroid function? Excess dietary iodine can inhibit thyroid hormone synthesis and release, referred to as the Wolff-Chaikoff effect, causing hypothyroidism. This effect is transient in normal individuals as the thyroid escapes from Wolff-Chaikoff. What finding on thyroid exam suggests anaplastic thyroid cancer? Hard, fixed, irregular thyroid enlargement rapidly emerging in the setting of dysphagia, dyspnea, hoarseness suggests anaplastic thyroid cancer which typically presents with aggressive local invasion. What antibodies are present in Hashimoto's thyroiditis? Hashimoto's thyroiditis involves autoantibodies directed against thyroid peroxidase TPO and thyroglobulin proteins within the thyroid follicles. Measuring TPO antibody titers assists diagnosis. What thyroid disorder involves a painful tender thyroid gland and elevated inflammatory markers? Subacute granulomatous thyroiditis causes fever, anterior neck pain, and tender thyroid enlargement along with elevated ESR and CRP reflecting inflammation.
How does amiodarone cause hyperthyroidism? Amiodarone's high iodine content leads to iodine-induced hyperthyroidism in some patients, caused by excessive thyroid hormone synthesis and release in response to the iodine load and destructive thyroiditis. What autoantibodies are present in Graves' disease? Graves' disease involves thyroid-stimulating immunoglobulins TSI that bind and activate the TSH receptor, as well as antibodies against thyroid peroxidase TPO and thyroglobulin. What is the most common cancer arising from follicular cells of the thyroid? Papillary thyroid carcinoma is the most common form of thyroid cancer, accounting for 80% of all cases. It arises from the follicular cells of the thyroid gland.
How does thyroid hormone regulate lipolysis? Thyroid hormone activates hormone-sensitive lipase leading to increased lipolysis and release of free fatty acids from adipose tissue. This contributes to the catabolic effects of thyroid hormone excess. What is the McCune-Albright syndrome? McCune-Albright syndrome consists of polyostotic fibrous dysplasia, café au lait skin pigmentation, and autonomous hyperfunctioning endocrinopathies like hyperthyroidism due to activating mutations in the NOS gene. What does a thyroid uptake and scan assess? A thyroid uptake and scan assesses iodine uptake efficiency and distribution within the thyroid gland. It can distinguish between hyperthyroidism, thyroiditis, and ectopic thyroid tissue versus a normal thyroid gland. What is the Wolff-Chaikoff effect in the thyroid gland? The Wolff-Chaikoff effect refers to the initial decrease in thyroid hormone synthesis in response to a large iodide load. It is a protective mechanism to prevent excessive thyroid hormone production in the setting of high iodine exposure. What are the indications for thyroid surgery? The most common indications for thyroid surgery include indeterminate or malignant cytology on biopsy, large goiters, symptomatic nodules or goiter, hyperthyroidism refractory to medical therapy, and cosmetic reasons. What are the different types of thyroid surgery? Total thyroidectomy involves removal of the entire thyroid gland. Lobectomy involves removing one lobe. Subtotal thyroidectomy removes most of the thyroid, leaving some posterior tissue. Near total removes all visible thyroid tissue. What are the potential complications of thyroid surgery? Complications include hypocalcemia due to hypoparathyroidism, recurrent laryngeal nerve injury leading to hoarseness, bleeding or hematoma, infection, and postoperative thyroid hormone abnormalities. How is postoperative hypocalcemia managed after total thyroidectomy? Patients should be monitored for symptomatic hypocalcemia after total thyroidectomy. Calcium and/or vitamin D supplementation may be needed temporarily until the parathyroid glands recover function. How would an injured recurrent laryngeal nerve present post-thyroidectomy? Damage to the recurrent laryngeal nerve can cause ipsilateral vocal cord paralysis leading to a hoarse, breathy voice. Vocal cord function should be assessed before and after surgery. How can you avoid damage to the parathyroid glands during thyroid surgery? Careful identification and preservation of the parathyroid glands is important. Meticulous hemostasis and avoidance of coagulation near the glands can help prevent devascularization or accidental removal. When is drain placement indicated in thyroid surgery? Drains are often placed with more extensive thyroid surgery to prevent fluid collection and help identify postoperative bleeding. Prophylactic drains do not prevent seromas or hematomas. What is the recovery process like after a total thyroidectomy? Patients experience several weeks of postoperative sore throat, neck pain, and fatigue. Voice changes are common. Activity is gradually increased over 2-4 weeks as incisions heal. Lifting restrictions initially apply. How would you manage a large postoperative hematoma compromising the airway? Large expanding hematomas require prompt surgical evacuation in the operating room with tracheal intubation or tracheostomy to secure the airway. Supportive critical care may be warranted. How is hypoparathyroidism managed long-term after total thyroidectomy? Chronic hypoparathyroidism may require long-term calcium and active vitamin D calcitriol supplementation. Regular monitoring of calcium levels is necessary to prevent complications. What factors increase the risk of recurrent laryngeal nerve injury in thyroid surgery? Known risk factors include reoperative surgery, extensive lymphadenectomy, large goiters, advanced stage thyroid cancer, and Graves' disease. Anatomic variations also increase risk.
How can recurrent laryngeal nerve monitoring help during thyroid surgery? Intraoperative nerve monitoring using endotracheal surface electrodes allows assessment of vocal cord function during dissection near the nerve. This may reduce injury risk and assist identification. What is the typical postoperative care after hemithyroidectomy? Most patients can be discharged home the same day after hemithyroidectomy. Analgesics and monitoring or treating hypocalcemia are priorities. Activity is reduced for 1 week before gradual return to normal. When is outpatient thyroid surgery appropriate? Outpatient thyroidectomy can be considered for healthy patients undergoing hemithyroidectomy or total thyroidectomy without extensive lymph node dissection provided no complications arise perioperatively. How does thyroid storm present postoperatively? Thyroid storm may present after surgery with hyperpyrexia, tachycardia, delirium, vomiting, diarrhea, dehydration, and hypotension from excess thyroid hormone release. Aggressive medical treatment is needed. How is a postoperative hematoma diagnosed after thyroidectomy? Clinical signs include acute neck swelling, pain, dysphagia, and potentially stridor. Ultrasound or neck CT confirms the diagnosis and guides needle aspiration or return to the OR. What features increase difficulty during thyroid surgery? Difficulty can arise from large goiters, substernal extension, extensive lymphadenopathy, invasion into surrounding structures, adhesions from prior neck surgery or radiation, and tendency to bleed. How is hypoparathyroidism screened for prior to discharge post-thyroidectomy? Serum calcium levels are checked after total thyroidectomy prior to discharge. Symptoms of perioral numbness and tetany should prompt repeat testing even if initial calcium is normal. When would thyroid lobectomy be recommended over total thyroidectomy for a thyroid nodule? Lobectomy may be appropriate for small low-risk cancers like low-grade microcarcinomas in patients at higher surgical risk or with comorbidities where complications should be minimized. How is recurrent laryngeal nerve function tested intraoperatively? Nerve monitoring uses electrodes to stimulate the vagus nerve and record signal transduction during dissection. Direct visualization assesses function at the end of surgery before closure. What is the typical postoperative radioactive iodine treatment timeline after total thyroidectomy for differentiated thyroid cancer? Radioactive iodine ablation is typically given 6-12 weeks after total thyroidectomy once TSH levels rise, to allow residual thyroid tissue uptake. Concurrent levothyroxine is withdrawn temporarily. How is central neck dissection performed during thyroid cancer operations? Central compartment lymph nodes are resected en bloc between the carotid arteries from hyoid bone superiorly to innominate vein inferiorly. Care is taken to avoid injury to vital structures. What does the American Thyroid Association recommend regarding prophylactic central lymph node dissection for papillary thyroid cancer? They advise that prophylactic central neck dissection may be considered for advanced primary tumors but should not be done routinely for small low-risk cancers. When would rapid steroid administration be indicated before thyroid surgery? Steroids given preoperatively can reduce inflammation and vascularity, which facilitates surgery for extensive Graves' disease, large goiters, and substernal extension. What measures can reduce postoperative nausea and vomiting after thyroidectomy? Antiemetics, proper hydration, and avoiding opioid analgesics when possible help reduce PONV. Minimally invasive video-assisted techniques can also lower the risk. What recurrent laryngeal nerve monitoring technique has the highest sensitivity? Intraoperative continuous vagal nerve monitoring using endotracheal tube surface electrodes allows constant assessment during dissection and has very high sensitivity for identifying nerve injury. How soon after thyroid lobectomy can patients typically return to desk work? Most patients can return to light sedentary desk work within 1-2 days after lobectomy provided pain and fatigue are tolerable, with activity advanced as the incision heals over the first postoperative week. Where is the thyroid gland located? The thyroid gland is located in the anterior lower neck, extending laterally from the midline and sitting just inferior to the larynx and trachea. It is situated anterior to the pharynx and esophagus. What is the thyroid gland composed of? The thyroid gland is composed of two symmetrical lobes, a connecting thyroid isthmus, and occasionally small posterior lobes. The lobes are made up of thyroid follicles surrounded by a thin capsule.
What are the key anatomical relationships of the thyroid gland? The thyroid gland sits against the anterior trachea just inferior to the cricoid cartilage. The recurrent laryngeal nerves run posteriorly along its lateral lobes. The parathyroid glands lie posteriorly. What suspensory ligaments help stabilize thyroid position? Two key suspensory ligaments are the pretracheal fascia and the lateral thyroid ligaments, Barry's ligaments, which attach the posterolateral thyroid to the cricoid and upper tracheal rings. What blood vessels supply the thyroid? The thyroid gland receives superior and inferior thyroid arterial branches off the external carotid and thyrocervical trunks respectively. The thyroid veins drain into the internal jugular veins. What is the thyroid capsule? The thyroid capsule is a thin membranous connective tissue layer that envelops the gland. It also extends septate inwardly to incompletely divide the thyroid parenchyma into microscopic lobules. What are parafollicular or C cells? Where are they located? Parafollicular C cells reside in the thyroid but do not produce thyroid hormones. They produce calcitonin and are scattered between follicles. Medullary thyroid cancer arises from C cells. How does the thyroid isthmus cross over the trachea? The thyroid isthmus overlays the 2nd to 4th tracheal cartilage rings. Alterations in isthmus size or position may cause tracheal compression symptoms. Where are the parathyroid glands located relative to the thyroid gland? Typically there are two parathyroid glands located on each side, an inferior and superior pair, adjacent to the thyroid's posterior surface near the inferior and superior poles. Histologically, what makes up thyroid follicles? Thyroid follicles consist of a single layer of follicular cells surrounding a lumen containing colloid, the extracellular proteinaceous substance rich in thyroglobulin and thyroid hormones. What anatomical spaces surround the thyroid gland? Spaces include the pretracheal fascia anteriorly, carotid sheath laterally, retropharynx and esophagus posteriorly, and the prevertebral fascia posteriorly.
Where are the parathyroid glands located relative to the thyroid gland? Typically there are two parathyroid glands located on each side, an inferior and superior pair, adjacent to the thyroid's posterior surface near the inferior and superior poles. Histologically, what makes up thyroid follicles? Thyroid follicles consist of a single layer of follicular cells surrounding a lumen containing colloid, the extracellular proteinaceous substance rich in thyroglobulin and thyroid hormones. What anatomical spaces surround the thyroid gland? Spaces include the pretracheal fascia anteriorly, carotid sheath laterally, retropharynx and esophagus posteriorly, and the prevertebral fascia posteriorly. What is the thyroglossal duct and what remnant may it leave? The thyroglossal duct forms during embryologic development as the thyroid descends from foramen cecum. Its persistence can lead to thyroglossal duct cysts along the tract. What important structures pass through the superior and inferior thyroid foramina? The superior thyroid artery and superior laryngeal nerve pass through the superior foramen. The inferior thyroid arteries and recurrent laryngeal nerve pass through the inferior foramen. What is the course of the superior thyroid artery relative to the external laryngeal nerve? The superior thyroid artery approaches the thyroid gland passing closely posterior to the external laryngeal nerve,
putting the nerve at risk during ligation.
What are the terminal branches of the superior thyroid artery? The superior thyroid artery terminates by branching into the anterior and posterior superior thyroid arteries which supply the thyroid gland. Where does the inferior thyroid artery arise from? The inferior thyroid artery arises from the thyrocervical trunk of the subclavian artery, then tracks upward behind the carotid sheath to the thyroid gland. Why do the recurrent laryngeal nerves have different paths on each side? On the right, it branches directly off the vagus nerve. On the left, it loops under the aortic arch, causing the asymmetrical paths.
What is the embryologic origin of the thyroid gland? The thyroid gland arises from a median endodermal thickening in the floor of the pharynx, then descends to its position in the neck via the thyroglossal duct. What helpful mnemonic summarizes the anterior neck structures from superior to inferior? Sir Charles Bell, voice, air, food, great vessels helps remember the structures inferior to the hyoid bone, submandibular gland, carotid sheath, larynx, thyroid, cricoid, trachea, esophagus. What are the anterior jugular veins? The anterior jugular veins drain the anterior neck and larynx, then descend on each side of the midline to enter the internal jugular veins or subclavian veins. What strap muscles cover the anterior surface of the thyroid gland? The strap muscles sternohyoid, sternothyroid, and omohyoid overlay the anterior thyroid surface. The anterior jugular veins descend along their lateral margins. What fascial layers separate the thyroid gland from the carotid sheath laterally? The pretracheal fascia covers the thyroid anteriorly, while the carotid sheath, containing carotid arteries, jugular veins, and vagus nerves, abuts it laterally. What important lymph node group receives drainage from the thyroid? Lymph from the thyroid primarily drains to the pretracheal and paratracheal lymph nodes located in the anterior central compartment of the neck. What key muscle overlays the posterior surface of the thyroid gland? The esophagus abuts the thyroid gland posteriorly. Contraction of the posterior cricoarytenoid during swallowing provides a key landmark for identifying the recurrent laryngeal nerve. What causes the thyroid gland to have an asymmetric lobular shape? The right thyroid lobe is often larger, extending superiorly over the isthmus and trachea. The left lobe extends superiorly only to the level of the isthmus. Where would an enlarged retrosternal goiter project into? As retrosternal goiters enlarge inferiorly, they project through the thoracic inlet into the anterior mediastinum, posterior to the sternum. Why is the thyroid gland very vascular? The thyroid receives a rich arterial supply to provide oxygen and iodine needed for rapid hormone production and secretion into the circulation.
What causes congenital hyperthyroidism? Congenital hyperthyroidism is caused by transplacental passage of maternal thyroid-stimulating immunoglobulins to an infant, leading to neonatal Graves' disease. What medications commonly cause hypothyroidism? Medications that can cause hypothyroidism include lithium, amiodarone, interferon alpha, interleukin-2, bexarotene, and tyrosine kinase inhibitors like sunitinib and imatinib. How does thyroid hormone regulate metabolism? Thyroid hormone increases basal metabolic rate and oxygen consumption in tissues by increased expression of genes involved in glycolysis, lipolysis, protein synthesis, and gluconeogenesis.